Hello and welcome to Fmge revision series of Global Academy of Medical Education GAME. So myself Dr. Sunabha, your Obs-Gyn faculty. I did my Obs-Gyn training from JIPMER, which is one of the premier institute of India. So first of all, congratulations on clearing your MBBS or equivalent exam from a faraway land and so much obstacles. So now we'll discuss about the easy part, that is cracking the NMC licentiate exam, that is the Fmge. So hang on tight for another 1 hour when we will be discussing, very quickly discuss entire obstetrics. And if you think I believe that you are on the pinnacle of your preparation and you know everything. So if you have any doubt at any point of time, please stop me and ask me a question. Okay, so we will be starting obstetrics from basic antenatal care when a lady comes to you with a positive UPT test. So this is basically the card. You can see this is a UPT card, and if you see, there are in this well, the first morning urine is put. And if there is only one line on the, this is control and this is test, one line on the control and no line on the test, then it is negative. If you see there is two lines, that is positive, control and test, then it is positive, like here. If you see there is no lines, or there is a line on the test but no line on the control, then this is a wrongly done test. This is a wrongly done test or a wrong kit, right? So what we try to detect here in the urine pregnancy test is the beta HCG level of urine, right? And beta HCG level of the blood is the most sensitive investigation. So most sensitive is a radio receptor assay, and most specific is a radio immunoassay of beta HCG of blood. UPT is earliest positive, remember, at 21 to 24 days of last menstrual period. So it comes before your negative UPT. It comes before missed period. So UPT precedes missed period, right? So coming to dating. So if she is aware of her LMP, we can add 9 month and 7 day. We can simply add 9 months and 7 day to reach the EDD, provided she has a 28-day cycle. If she has a 35-day cycle, then 28, 35 difference is 7. So you have to increase 7 days. And if she is having a 24-day cycle, regular cycle, then 28 to 24 difference is 4 days. So the EDD will be 4 days earlier, like that adjustment has to be made. So once we get the EDD, how much reliable this EDD will be? So if she has 3 points positive, 3 points are: 1, she is sure of her date; number 2, her cycles are regular; and number 3, she is not using any hormonal medication or anything, then it is called a good dating. Now, if that good dating corresponds to a first trimester ultrasound dating, especially 9-week CRL, especially 9-week crown rump length measurement, then it is an excellent dating. And if these two are not matching, then we have to go by the 9-week CRL, because first trimester, especially 9-week USG measurement of the data is excellent, is the best one. And what is suboptimal dating? If somebody is having no first trimester scan and not sure of dates or irregular cycles, then it is a suboptimal dating. So coming to the trimester timeline, I hope you all know that till 12 weeks is trimester 1, first trimester, that is mostly known for the organogenesis. And this is the second trimester, where most of this growth is happening. So second trimester lasts up to 28 weeks, and after 28 weeks till delivery, it is trimester 3. So trimester 1, trimester 2, and trimester 3. So what is the term timeline? So from 28 weeks I'm taking. So beyond 28 weeks, it is extreme preterm. So preterm that Government of India doesn't even recognize it as a viable fetus. Okay. So less than 28 is extreme preterm. Now 37 weeks is the term. Beyond 42 we call it post term. Beyond 42 is post term. Okay, so here is one more mark I am putting 40. Okay, and here I'm putting one more arbitrary point, not arbitrary exactly, 34, and here I'm putting 32. So 28 to 32 is called very preterm, 32 to 34, anything before 37 is preterm. Okay, know that anything before 37 is preterm, because 37 to 40 is term, 37 to 40 is 37 to 42 is term, 40 is where the EDD is. 40 is where the EDD is. Only around 3% babies born on the EDD, right? So 32 to 34 is known as moderate preterm, and 34 to 37 is known as late preterm. Why so? Because at 34 the lung is usually overall mature, and 37 is the point where lung maturity is complete. That's where the term comes. So 37 to 40. Now if we see 37 to 40, 37 to 39 is known as early term, 39 to 40 is the term, and 40 to 42 is actually late term. Okay, late term. And beyond 42 it is post term. Remember, beyond 40, like 42, 42 and beyond, it is also known as post dated, because the EDD, the date, expected date, gets over, right? So come on, next, coming to the booking visit. So when the first visit the woman makes to the obstetrician with a positive UPT, so what are the investigations that we will do? So first investigation that we will do is the grouping, then hemoglobin. If you have facility, you can do CBC, that is complete blood count, or a complete hemogram, but hemoglobin is what is recommended by the government of India. So are we supposed to do HPLC or thalassemia screening? Thalassemia screening, according to government of India, is a part of post-marital counseling when they are trying to conceive. So if they have not done before marriage, it is better to suggest them, but not exactly absolutely recommended. Serology, HIV, HBsAg, VDRL, and anti-HCV is coming up. So these three are mandatory, and this one is coming up. Remember, HIV is known as opt-out testing, because if the lady doesn't say anything, it will be done for her, but she has her own right to opt out from testing. Like in surgeries and all, we ask for consent, like, can we do this surgery on you? Opt out is just a little different. It is, if you don't say anything, we will be doing that test on you. If you specifically actively say, no doctor, don't do this test on me, then we will do not do, right? And then screening for gestational diabetes, screening for thyroid function, urine culture to screen for asymptomatic bacteria, and a first trimester ultrasound to understand dating, number of pregnancy, location of pregnancy, and cardiac activity, right? So whether it is an ectopic or not, to rule out ectopic. Okay, and what are the medicines that we give? Torch screening is recommended? No, absolutely not. So folate is definitely to be given 0.5 mg per day if she has no history. If she has a history of 0.4, if she has a history of previous neural tube defect, then 4 to 5 mg OD. Remember, 4 mg tablet is not available in India, so what I give is 5 mg, but recommended dose is 4. Okay. Vaccination, yes, in India, what we do is we give TT vaccine on the first visit itself, because follow-up is an issue here. If we give her a vaccine, if we don't give her a vaccine, and next time she might be coming at labor. So that is one problem. So on the first dose, Otherwise, if you are practicing in a setup where patients are aware and coming to follow up regularly, where you can bring them to follow, then you can defer it till the second trimester. So doxynate is not a routine medicine. It is a medicine for hyperemesis gravidarum or excessive vomiting in pregnancy. Progesterone support, again, if it is indicated, if there is a threatened miscarriage or short cervix. And HCG is also a drug which is often used to prevent a threatened miscarriage or support a pregnancy, but otherwise not routinely recommended. So, what are the history that we take on the booking visit? Three things: gravida, parity. So, gravida is total number of pregnancy, right? Including the current one. Okay, and parita is total number of previous pregnancies that has crossed viability, that is 28 weeks. We say 28 weeks is the viability. So this is one that considers the current pregnancy, this one doesn't. Okay, so if somebody had, like, 5 deliveries in the past, delivery plus abortion, total 5 pregnancies in the past, and this is her current pregnancy, then it becomes G6. Whereas if she has, among those 5, only 2 of them cross 28 weeks, then it becomes P2. Now, if one of them is alive now, so ill comes as a notation for number of live children, and rest of them are like abortion. Okay, rest of them are counted as abortions. So 3 abortions, 2 that has crossed the viability, only one of them is alive. So these are the kind of notation. Now what happens in case of twins? In case of twins, para is only 1 because there is a single pregnancy that has crossed the viability, but number of live will be 2, right? So previously this abortion was written as, this is actually the P and this is actually the A. That is old notation. Like if we write this one like this, then we will write G6 P2 plus 3. So this is an old notation. I don't think you need to know. So we must do a pervaginal or bimanual examination on the first examination itself. And uterus by 6 weeks is like an hen's egg, by a cricket ball by 8 weeks, and it is the size of fetal head or just palpable parabdominally by 12 weeks. Okay, so this is very important topic, early pregnancy signs. And just know the name of the sign, Jack Vermer. First understand that these are all progesterone effect. Okay, so progesterone causes dilatation of vessels and relaxation of the sphincters. So a dusky hue of the vestibule, because excess flow. Now what is Osiender's sign? Excess flow, pulsation felt. What is Goodell's sign? It softens the cervical smooth muscles or connective tissues. What is Piscasek sign? Piscasek sign is basically asymmetric enlargement of the uterus, because the implantation is rarely bang on the center of the fundus. It will be slightly on the one side, and that will be appreciated. Hager sign is seen in 2 to 3% of the things, and it is like the cervix is soft, so the external loss is felt as a mass, and the gravid uterus is felt as a mass. So there is, like, it is felt like 2 balls. That is the thing, Hager sign. And Palmer sign is something that is very important. It's rhythmic contraction of the uterus. That is basically the uterus prepares itself, and uterus does a genetic check on the fetus, and if the uterus feels that this has a genetic defect, so it will increase those contraction, and first trimester abortion will happen. So at the same breath, remember, first trimester miscarriage, most common reason is genetic abnormality. So coming to the investigations that we are doing one by one. So blood grouping, we have 36 systems of blood grouping and 360 antigens right now. Okay, so the most important we need to know are the ABO, and then CDE, which was formerly known as RH, and then there are other smaller ones like KEL, Duffy, KID, MNS, all these things. Remember, KEL is idiosyncratic. Like if there is kill isoimmunization, the baby will either be very bad or will not be affected at all. On the other hand, RH, if the mother is isoimmunized, if the mother develops immunity against the baby will be damaged based on the mother's immune titer. Okay, so that is what the importance of kill. So this is ICT and DCT. I hope it has been discussed in pathology already. So DCT is direct Coombs test, which is done from the fetal blood, fetal blood is taken and fetal serum is taken, and testing is done for antibody. Here the mother's blood is taken. ICT indirect is from mother's blood, and DCT direct Coombs test is from fetal blood. That's what you need to know. Okay, so how does the mother gets immunized against the fetus? So there is something called fetoplacental hemorrhage that can happen in any of these situations. Take a screenshot and revise later. Ectopic pregnancy, spontaneous abortion, or some procedures like chronic villus sampling or amniocentesis fetal blood sampling, or at the delivery, or abdominal trauma or placental abruption, or during the external cephalic version. So how to understand if that has happened? There are bedside tests like acid precipitating test, or there is Clower-Betke test, which is alkali precipitating test. This is semi-quantitative. If you ask me what is the best test is the flow cytometry. So we saw that there are the previous ectopic pregnancy, previous spontaneous abortion, elective abortion, fetal death at any trimester, all these events. So can a primee who has never been exposed to another baby before can get a isoimmunization? Yes, if she has received positive blood group before, or if she has undergone any of these procedures: amniocentesis, fetal blood sampling, chorionic villus sampling, or an abdominal trauma, she is undergoing placental abruption, or an external cephalic version. All these things can happen, or there is something known as grandmother effect, where basically the mother is having all those anti-D antibodies inherited from her grandmother, right? She is not produced, she inherited those antibodies, right? This is a complex phenomena, and this is not the right place to describe. So this is Claire-Butke test, how it is done. This is alkali washout, and you can see all these cells. These are called the ghost cells, which are already washed out, and these cells which are surviving are the cells with fetal hemoglobin F. So basically we assume that all the RBCs with fetal hemoglobin is the fetal blood, and all the RBCs that has turned into ghost cells contain adult hemoglobin are mother cells. So the limitation is based in this assumption only. So if the mother is thalassemia, then a good number of mothers RBCs contain fetal hemoglobin. So the fetal hemorrhage is overestimated, right? Overestimated. On the other hand, if it is a term baby, 80% is fetal hemoglobin, 20% is adult hemoglobin. 20% adult hemoglobin in term baby. Right? So it is underestimated. Fetal hemorrhage is underestimated. Right? So this is the formula by which we do the KB test. So what is to be done in a D mismatch couple? That is, if the father is positive and mother is negative, the lady is negative and the man is positive. So what to do? We need to do ICT once at the beginning and then monthly. Okay, and after delivery 300 microgram, that is equivalent to 1500 units of anti-D injection, has to be given to the mother on the deltoid muscle. On the deltoid muscle, IM. Okay, don't forget this deltoid muscle, IM. Antenatal dosing of anti-D is a recent thing that we give at 28 and 32 weeks, sometimes 34 weeks. one dose or two dose, usually 32 weeks one dose or 28, 34 two doses to prevent. But remember, even if we give antenatal anti-D, that doesn't mean that we will not give postnatal. So postnatal, if baby is of positive blood group and DCT is negative, we must give this 300 microgram or 1500 international unit of anti-D to the mother to prevent complication in the next pregnancy. So how do we manage an RH sensitive pregnancy? We do ISHT titer every 4 weeks, and if it is beyond critical titer, then we monitor fetal anemia by USG, middle cerebral artery maximum velocity. This is called peak systolic velocity as well. And if it is more than 1.5, means multiple of median, then we need to transfuse. Then we need to transfuse the fetus because of hemolysis, and this is known as intrauterine transfusion. Okay, Lilly spot and amniotic fluid bilirubin, these are all old things and not performed nowadays. So what can happen if the fetus is getting severely anemic? The fetus can develop hydrops. So here you can see a hydrops baby, and you can see the placentomegaly, like placenta is as big as the fetus. Usually placenta is 1/6 of the fetus, right? So what is the criteria for fetal hydrops? There should be pleural effusion, pericardial effusion, ascites, or anasarca. Anasarca is a generalized thickness or skin thickness more than 5 millimeters. So any two of these four has to be present. Placentomegaly and polyhydramnios, even though is seen together, is not a diagnostic criteria. So don't get confused. One of the third space fluid accumulation should be there, either pleural or pericardial or abdominal or in the skin space. So this is intrauterine transfusion being done. You can see this, like the structure of the umbilical cord is AVA, right? So there is one vein and two arteries. So if I can zoom, you can see this is one vein and these are the two arteries. This is also known as the Mickey Mouse sign. So you can see this is the needle coming, and needle is piercing one of the veins. Needle is piercing one of the veins. You can see here also the needle has pierced one of the veins in the transverse section. So what is the blood that we transfuse to the mother? So to the fetus. So this is O negative, D negative or Rh negative formerly, cytomegalovirus free, a very concentrated blood, hematocrit 80%, irradiated to make it leukocyte poor, right? So remember this, and this calculation is actually not required. So coming to a most important topic, I think anemia in pregnancy, and remember this, the Anemia Mukt Bharat logo, and this is the government program, and we will just slowly discuss the three cutoffs. So WHO says 10 to 11. 11 is the minimum, that is everybody says. Below 11 everything is anemia. So 10 to 11 is mild, 7 to 10 is moderate, and below 7 is severe. That is what WHO says. Now what Fmge additionally says is 10 to 11 is mild, same, 7 to 10 is moderate, then less than 4 is very severe, and 4 to 7 is only severe. Now WHO doesn't have that. Now Government of India, what does it do? It changes this 4 to 5. Okay, so 0 to 5 is very severe, then 5 to 7 is severe, 7 to 10 is moderate, and 10 to 11 is mild. What everybody agrees is, previously it was like 9 to 11 is mild, but now everybody has moved from that. So anything below 10 is moderate, that everybody agrees. Okay, so the confusion is between whether or not they have to put something called very severe or not. Or one more controversy is like whether to call less than 4 very severe or less than 5 very severe, right? So better to go by the Government of India guideline. So what is the iron preparation? The classical iron and folic acid and other inorganic and organic salt chelate form. Now heme form iron has also come as a commercial preparation. But what is more important is knowing the par-enteral combination. So ferric carboxymaltose can be given 500 to 1 gram in a single day over 20 to 30 minutes of infusion and can be repeated monthly. Okay, and iron sucrose, on the other hand, can be given 100 to 200 milligram per day, but can be repeated alternate day, right? So iron sucrose and FCM, and there are older preparation, iron dextran and all that I don't think you need to know. You need to know Ganzoni formula. Ganzoni formula is 2.4 minus hemoglobin difference. That is, if my target hemoglobin is 11 and her hemoglobin is right now 8.5 into body weight, say 60 kg plus 500 for stores. So this entire value in mg is the actual total dose. So like this we can calculate. So this is a very important table. This table, if you go to the GAMEPG app or my profile at Instagram, Dr. Sunabha, Sunabha, you will find this one chart pinned on the first comment. And this is a very important topic, when to do what. Like if there is severe anemia that is less than 7, if it is between 5 to 6.9 at any gestational age, if it is less than 5 at any gestational age, hospitalization and immediate transfusion. Whereas if it is between 5.0 to 6.9, if it is less than 34 weeks, so we have time, we can try IV iron with FCM or iron sucrose. But if it is more than 34 weeks, we need to transfuse. So if it is anemia of say 10 to 10.9 and gestational age is less than 34, and she is compliant to iron folic acid, then we can make iron folic acid dose double. And if improvement of hemoglobin is 1 gram per dl after 1 month, then we can continue with the same treatment. It is like, there is an absolutely algorithm based, and this is something you need to know by heart. Go through this table. This table is available everywhere. You can find it under my Instagram handle, Dr. Sunabha. So coming to next thing, thalassemia in pregnancy. Remember, all these IV irons have no role in thalassemia of pregnancy, because thalassemia of pregnancy is not because of iron deficiency but hemolysis, and there is actually an iron overload going on. So thalassemia in pregnancy has to be treated with transfusion as and when required. Let us come to difficult topic, HIV positive pregnancy. So HIV positive pregnancy is countered by HAART, highly active antiretroviral therapy, and that therapy is much better than zidovudine monotherapy, which was previously recommended. So if RNA copy number is high or CD4 count is less than 400, then it is severe HIV infection. And if less than 200, then opportunistic infection prophylaxis, like prophylaxis for pneumocystis jirovecii and all are recommended. So HIV can cause FGR, microcephaly, hypertelorism, prominent forehead and flat nasal bridge. Remember, CD4 count and USG to be done at least once in every trimester, and if copy number is high, that is more than 1000, we need to deliver by cesarean, because perinatal risk of transmission is very high. And once the neonate is born, neonate is to be screened and treated adequately for HIV. So what to do if somebody comes with VDRL positive? So VDRL is one more serology test, which is a test for syphilis, but VDRL, remember, is a screening test. So if somebody is VDRL positive, right away we cannot say that they are having syphilis, right? So we need to confirm it with the treponemal test like FTA-ABS that I think you will be taught in microbiology. And if that also comes positive, then if it is still early latent, we have to give 2.4 million um, benzyl penicillin, 2.5 million units IM stat. If it is late latent, then weekly, same dose, weekly for 3 weeks. If it is tertially, then same dose once daily for 14 days. And if VDRL falls by titer falls by 4 times, treatment is considered complete. Now, what are the features of congenital syphilis, stillbirth? Now, there's a particular thing about syphilis. Syphilis, the fetal prognosis improves with each case, right? If the first case is a first trimester abortion, the next one will be term IUFD, the next one will be delivery of a congenitally abnormal fetus, whereas there is another condition that is, APLA or your RH incompatibility. All these prognosis will worsen over time. So if first one could pull till 34 weeks, the next one will go till 28 weeks, and next one will probably land up in abortion. So syphilis prognosis is better, so we get to see a lot of congenital syphilis. And there are many stigmata of congenital syphilis which will be dealt in pediatrics extensively, so I'm not going into that. So HPS AG positive pregnancy, that is hepatitis B positive pregnancy. Transmission depends on HBeAg and DNA copy number, lamivudine or tenofovir. Tenofovir is given to the mother to reduce transmission, and neonate is given the vaccine as well as the immunoglobulin immediately. So coming to TORCH screen for toxoplasma, remember trimester 1 transmission is less but sequelae is very high, whereas later trimesters transmission is high but sequelae is very less. So what we need to do is we test IgG. IgM is not reliable in these case of infections, right? So IgG avidity testing we do, and if avidity is high, that means the antibodies are experienced antibodies, which means it's an old infection. And if it is old infection, that means it's not a primary infection. Transmission is only during primary infection. So if it is an old infection, we need not to worry. But if avidity is low, then it's a recent infection. So we need to worry, right? So in that case, we need to do fetal amniotic fluid PCR. So if mother is toxopositive, we need to see PCR of the fetus by amniotic fluid PCR. Now, if the fetus is also infected, then MTP is justified. If she doesn't want MTP, then sulfadiazine and pyrimethamine with folic acid can be tried. If fetus is not infected, then mother is treated with spiramycin. So what is the typical feature of toxoplasmosis? Hydrocephalus, chorioretinitis, and intracranial calcification. Remember, it is intracranial calcification. We'll see the contrasting things later on. Okay. So there is another thing, rubella. So rubella has congenital rubella syndrome, sensory neural hearing loss, cataract, PDA, and also microcephaly. So this is called the triad of congenital rubella syndrome, and that is what is most important. Now coming to another one of the TORCH screen, CMV. So CMV presents with periventricular calcification. So that was cerebral calcification. This is periventricular calcification. Deafness, SNHL, sensory neural hearing loss. Chorioretinitis. See, the choreo part of the eye, the neuro-ophthal part, it's a part of brain, So where the brain is involved, chorioretinitis is also common. So if you see suddenly cataract, that is what is atypical. Chorioretinitis is pretty much seen everywhere. So this also leads to mental retardation, microcephaly, and also jaundice, hepatomegaly, and PTG all over. So you can remember this cartoon, so it will help you. Okay. Coming to another TORCH infection, herpes. Herpes is genital lesion and it's a genital transmission, so cesarean is absolutely recommended to prevent infection. Even if rupture of membrane has happened more than 4 hours, so we can assume that the contact has already been established, even then cesarean, the baby is not allowed to pass through the genitals of the mother. Acyclovir, valacyclovir, famiciclovir, all of these are used in treatment. So this is next one, pox. Pox is a very severe infection in the mother, leads to around 1% of total maternal mortality, and highest transmission is seen from 5 day before to 2 day after rash. So if the mother is seronegative, then mother should receive varicella zoster immunoglobulin. If the I'm sorry, the baby, if the baby is developing chicken pox, then acyclovir should be started, and if there is VZV pneumonia, IV acyclovir is needed. So what are the features of congenital varicella syndrome? Remember two things. See, this chorioretinitis cataract, this is common. Limb hypoplasia and cutaneous cicatrization, cutaneous scarring, like in this picture. So these two are very, and you can see the arms are short as well, right? So limb hypoplasia and cutaneous cicatrization, these are the hallmark. So another is parvovirus. It's a single-stranded DNA which is rare. It can cause very dangerous effect in mothers who have sickle cell disease, pre-existing hematological conditions, or are immunocompromised. Okay, so in fetus, it can cause myocardiopathy, cardiac arrest, and fetal death, or bone marrow aplasia leading to anemia, leading to high drops, and might need intrauterine transfusion. Coming to the next one, diabetes in pregnancy. So, diabetes in pregnancy, why there is diabetes in pregnancy? Because of a substance called human placental lactogen that is most commonly secreted at 28 to 28 weeks by the mother. So, testing should be done at screening, should be universal. Screening is universal, and Government of India recommend tests at first contact and once more between 24 to 28 weeks. Now remember, there should be a 4-week gap between these two. So if you are doing the first test at say 20 weeks, the next test can be at 24 weeks. But if you are doing the first test at 23 weeks, then the next test should be done at 27 weeks. And if it is done at 24 weeks, again a second test is to be done at 28 weeks. If you are doing at 26 weeks, at 30 weeks, second test has to be done. But if the first test is beyond 28 weeks, like 29 weeks, then there is no need for a second test. Okay. So this is the Western guideline of OGTT, which is not recommended by the Government of India. So fasting is 92, first hour is 180, and 2-hour plasma glucose is 153. 2-hour plasma glucose is 153. But Government of India recommends a test called DIPSI that doesn't encounter for fasting, and if DIPSI is more than equal to 140 milligram per deciliter, then we call this as a gestational diabetes. Government of India doesn't differentiate between overt diabetes and gestational diabetes, but if just diabetes is there when the organogenesis is happening, at that point the congenital malformation risk is higher and there can be an FGR baby. On the other hand, if the uncontrolled diabetes is encountered in the later part of the life during growth phase, so baby is getting higher sugar, so baby will produce higher insulin, and with insulin comes insulin like growth factor, so this will lead to abnormal fat deposition around the shoulder and overall a big baby. So that is the difference between overt and gestational diabetes. So let us come to the FAQ discussion. Most common system involved in diabetes, CVS. Most specific, CNS. Most common in CVS is VSD. Most specific in this is DTGA. Okay. And most common in CNS is neural tube defect. And most specific in CNS is caudal regression syndrome. Okay. So this is the most specific symptom, and among these, this is the most specific. So caudal regression syndrome is overall most specific, right? And overall most common is most common system, most common manifestation, VSD. So this is overall most common. Remember, reversible HCM, hollow prosencephaly, imperforate NS, these are also seen. So there are certain features that we can see. This sudden IUFD, which is predictable by NST though. Sudden IUFD, but NST predictable, and this is because of a chronic hypoxic state in the baby, and lactic acidosis, because there is high sugar, there is to metabolize that by Krebs cycle, there is high oxygen demand. If that oxygen demand is not met, there is hypoxia. And if there is hypoxia, then they have to do glycolysis and then finally lactic acid, and that leads to acidosis. So that is predictable by NST but can cause fetal death. And the baby is habituated with higher glucose load from the mother, and so baby has higher insulin. Now once the baby is out, there is higher insulin but no high sugar, so there is neonatal hypoglycemia, right? Macrosomia or FGR both can happen. Remember, this I have already explained. Hair on ears is a very typical feature of baby of a diabetic mother, and fat deposition around the shoulder, which leads to shoulder dystocia, like difficulty in delivery of shoulder. Okay, so these charts are again very important, and you can find this on Instagram, my account, or the GamePG app. So my account is DRSUNABHA on Instagram, or at the rate GamePG app. So both these accounts you can be able to find my posts. So this chart is of calorie calculation, what is to be given to a diabetic mother. So what to do when somebody's sugar has come more than 140. So we start this particular diet and exercise 30 minutes of brisk walk at least 5 days a week, and we check ppbs. We check ppbs after 2 weeks. So if ppbs is still 120 or more, we need to start medicine. If it is less than 120, then we can continue with our diet and exercise, which is known as the medical nutritional therapy, or MNT. Medical nutrition therapy. Okay. So what if this ppbs is more than 120? Then we have to introduce insulin. This chart is again available at my Instagram account, Dr. Sunabha. Every document is shared there. Now remember, only premix insulin 1370 subcutaneous is to be used, and the only 2 doses are before breakfast and before dinner. So if fasting is high, we need to increase before dinner. If ppbs is high, we need to do before breakfast, and every 3 day we need to do fasting or pp. Now apart from this insulin, what can be added is metformin. Metformin can be started 500 mg BD and can be raised up to 2 gram per day. Remember, metformin to be started only after 20 weeks, not before 20 weeks. Before 20 weeks, insulin is the drug of choice. So managing gestational diabetes in labor needs more stricter control, and buffer dextrose insulin or sliding scale or variable dose insulin is used. Cesarean delivery is recommended only if the baby is 4.5 kg or there is some other indication for cesarean. Remember, this is 5 kg for a non-diabetic mother. Okay, so what is macrosomia? Macrosomia is more than 4 kg for a non-diabetic mother, and more than 4 kg for a diabetic mother's baby. Estimated fetal weight. How to estimate the fetal weight? Either by clinical biometry or by this formula. This is Master Johnson's formula. This n depends on n's value is not fixed, depends on how engaged the baby's head is, and USG biometry is definitely the best way to estimate the fetal weight. Okay, so we were discussing shoulder dystocia. Shoulder dystocia is basically when the obstetrician feels there is a difficulty in delivering the shoulder of the baby. So what to do? Call for help, empty the bladder and deepen the episiotomy. That is the first step. Then second step is suprapubic pressure. Then try to deliver the posterior shoulder. McRoberts maneuver is hyperflexion of the hip McRoberts maneuver is hyperflexion of the hip and putting her on all fours, that is Gaskin maneuver. Zavanelli is pushing the baby inside and doing the cesarean. Wood's corkscrew maneuver, Rubin's corkscrew maneuver, clavicle fracture, and symphysiectomy are all the methods. So this is an image of sacral agenesis. You can see that the vertebral is formed, but sacrum there is hollow. Here also you can see there are parts of innominate bone but no sacrum and one small long bone. So this is known as a marmaid fetus. This is known as a marmaid fetus. Okay. So coming to the crux of the obstetrics, pelvis and fetal dimension. So I'm not going into the very details of this thing because you already know. So remember, inlet is pelvic inlet is like this. So anterior diameter is roughly 11 centimeter, whereas transverse diameter is 13 centimeter, oblique diameter is 12 centimeter. Cavity is round and all the diameters are 12 centimeter. And outlet is like this. So this is the symphysis pubis. These are the two ischial spines. This is the interspinous diameter and this is the transverse diameter as well. This is 10.5. You can write it as 11. And this is symphysis pubis to tip of the coccyx, which can get extended till 13 centimeter, right? So 11, 12, 13. 13, 11, there is no transverse diameter here and all 12 for this. Now, we are talking about coccyx, and when there is coccyx is like this, a synovial joint. So, when the baby tries to pass, it will go back and let the baby come out. So, we need to understand a fixed point. So, if this point is negotiated by the baby, rest the baby can manage by pushing the coccyx back. So if we supplement this point by the fifth sacral vertebra, fifth sacral vertebra, then what we get is the plane of least pelvic dimension, right? So this is the plane with ischial spines, posteriorly fifth sacral vertebra and anteriorly symphysis pubis, right? So now ischial spine is where the levator ani muscle is attached. And when the head touches the levator ani, it is almost always asymmetrical and hence levator ani pushes the head with different force and head turns. So this is the position where rotation of the head happens, where internal rotation of the head happens, right? And once there is internal rotation, the baby can move forward direction. From downward direction, baby moves the forward direction. So this is the forward direction of the birth canal, starts from this point, right? So this is of course the narrowest plane of the pelvis. This is the origin of the levator ani muscle. This is the plane where internal rotation happens. Now if internal rotation fails to happen, then it is called deep transverse arrest because internal rotation is not happening and it is stuck deep. So this is deep transverse arrest. So this is the plane of deep transverse arrest, and this also marks the beginning of forward curves of pelvic axis. Now this levator ani muscle is supplied by the pudendal nerves, right? So if we need to block the pudendal nerve, this is the landmark. So this point, you understand, is a very important plane. So this is arbitrarily defined as station 0. So whenever the presenting part, the head or whatever it is, reaches this point, we call head station 0. Anything minus 1 centimeter above it is minus 1 station, minus 2, minus 3, like that till minus 5, or anything below 1 centimeter is plus 1, then plus 2, then like that plus 5. Plus 5 is like head perineum, okay? So this is defined as station 0. This is again a very, very important slide. Very, very important slide. Now, abnormal pelvis, you should know these 4 types of pelvis: gynecoid pelvis, anthropoid pelvis, android pelvis, and platypelloid pelvis. Numbers are there everywhere. So you need to know what percentage of pelvis is of this type. Now, anthropoid pelvis is like monkey-like. This is anteroposteriorly enlarged. This is male type pelvis with very deep sacral indentation and a heart-shaped cavity. And this is platypelloid. This is very shallow pelvis. One more shallow pelvis is seen in achondroplasia, which is known as the champagne glass pelvis. Champagne glass deformity. Deformities are also seen in osteomalacia and rickets. the triradiate and rachitic pelvis, there is a particular type of pelvis which you need to know is where the ala of the sacrum is congenitally absent. So instead of like this, the sacrum is either having one ala or no ala at all. So if it is this, this is known as the Naegeli's pelvis. This is the same Naegeli who give that 9-month 7-day EDD calculation formula. And this is, if bilaterally it is absent, it is known as Robert pelvis. Also, if you imagine a lady who has polio, so this leg is comparatively weak, and this is comparatively a stronger leg, so she bears her weight on this leg, so this side of pelvis will be tilted, right? So if this is a normal pelvis and more weight is borne by this side, then the pelvis will become like this. This is an asymmetrically abnormal pelvis, and this is what is exactly shown in PRP, that is persistent residual polio paralysis. And also, if the vertebra is bent, then the pelvis will be bent accordingly. So fetal skull, again, dimensions, this chart is there everywhere. I will not waste time here. Just I will teach you how to remember the diameters. Ignore this one, okay? For sometimes ignore this one. So 9.5, 11.5, 14, then 11.5, then 9.5. Vertex, brow, face. And remember, brow is partial extension. This is 14 centimeter. So in pelvis, there was no 14 centimeter, right? The maximum diameter was 13. So this will not pass vaginally, and this one needs cesarean. Brow presentation always needs cesarean. So the position is the the direction of the longitudinal suture and the occipital bone in terms of the maternal bone. So most common position is left occipitotransverse, while the longitudinal suture is exactly corresponding with the transverse diameter, whereas when it corresponds to the anterior-posterior diameter is direct diameters, occipito-anterior and occipito-posterior. Occipito-posterior is the rarest, and normal delivery is possible but difficult. So coming to the adjustment mechanisms, molding grades are very important. So when the two bones touch each other, it is grade 1 molding. When they overlap but can be brought down by pressure, it is grade 2 molding. And grade 3 molding is like when they overlap and doesn't come back at all. Okay, so asynclitism, you just need to know two things. Posterior asynclitism is seen in primi mothers, whereas anterior asynclitism is seen in multi. Right? So this is the thing of asynclitism and molding. Now, this is the importance of anterior frontanelli that I don't want to waste time on. You can take a screenshot and read later, or your pediatrics faculty will definitely be taking. So caput succedaneum versus cephalhematoma. So what is caput succedaneum versus cephalhematoma is something that caput is when the head tries to negotiate, there is tissue edema because of reduced drainage from this part of the scalp. So there is a diffuse tissue edema. The head skin becomes, the scalp becomes thick. It's a diffuse thickening. On the other hand, if by birth injury one of the periosteal vessels are torn, within that particular bone there will be hemorrhage and the periosteum will bulge. So basically it's within the periosteum, this will be limited by the suture line. Only one particular bone around its suture line will be swollen, right? And it will contain blood. On the other hand, caput succedaneum is fluid edema and it extends beyond suture line because it's on the skull. This is present at birth and resolves within 48 hours, whereas this develops from day 1, not present at birth, and takes months to resolve. Now, let us just see the events of normal labor. So, engagement is when the longest diameter crosses the usually the biparietal diameter, it crosses the pelvic inlet. It is known as and enters the pelvic cavity, it is known as engagement. Then flexion is a continuous event. Internal rotation happens when the head hits the when the head hits the levator ani muscle asymmetrically, and then descent happens. Descent and flexion are continuous process, and then there is an event called crowning, which is not exactly an event of the labor. So crowning is basically when the head, like with contraction, the head comes out and then recedes, comes out and recedes. So after a certain point, the head will be so much out that it will not recede with relaxation, and that point is known as crowning. So after crowning, the head delivers by extension, and then this internal rotation that happened, this was 1/8 of a circle. So untwisting of that neck will happen, and that is known as restitution. And after that, 1/8 restitution, and after that what will happen is that at this point the shoulders are touching the levator ani. So shoulders will undergo internal rotation, and that will be seen as external rotation 1/8 of the head. And after that, the shoulder will deliver by lateral extension, and the body will deliver by the lateral extension. Now see one thing here, the anterior shoulder presents first. See, when the anterior shoulder is already out, the posterior shoulder has not come out, right? But so anterior shoulder crowns first, anterior shoulder crowns first, but you see now the anterior shoulder is hinged and there is a lateral flexion happening delivering the baby. So posterior shoulder has come out. So posterior shoulder delivers first. Okay. Next we will come to discuss the stages of labor. So stage 1 is from the uterine activity causing cervical changes to full dilatation of the cervix. Stage 2 is full dilatation of cervix to delivery. Stage 3 is from delivery to placental delivery. And stage 4 is very important. It is 1 hour after the placental delivery, that is the golden hour for PPH, for postpartum hemorrhage. And stage 1 is defined at divided in 2 phases, the active phase and the latent phase. So progress of labor is basically measured by the partograph, and we have put a detailed description in partograph for the GAMEPGAPP YouTube channel. The video is at the GAMEPGAPP YouTube channel, so you can find out there. Bishop score is a scoring to understand the cervical favorability. Cervical favorability. This chart you can find everywhere, so I am not going into the detail of it. Remember, the minimum score possible is 0 and the maximum score possible is 13. And a score more than or equal to 6 is considered as a favorable cervix. I will just highlight the Fmge modifiers. So once the score is determined based on the cervical factors, based on the mother's history and presentation, we need to modify the score to make it clinically more significant. So if it's a primi or nulliparous, or there is pre-labor rupture of membrane, or there is post-dated pregnancy, then we have to -1. On the other hand, if there is pre-eclampsia, we need to add 1, and for each vaginal delivery, we need to add 1 point. So partograph and the newer generation partograph, the WHO labor care guide, has been described in details in our YouTube channel. So please do subscribe to that YouTube channel and go through. These are short videos, high yield topics. So even if I rush on it, it will not help you. So I request you to go through those contents. These 3 logos you should always know. This is the World Health Organization logo on maternal care. See the presence of the husband in this image. Okay, that is very, very important. That is what the WHO has preached nowadays. Okay, and this is the guideline. This is a WHO program. This is a Government of India, Ministry of Health and Family Welfare program. So this is Lakshya. Lakshya talks about the labor room quality. And this is a Foxy initiative. This is known as Manyata. This is known as Manyata. Manyata is all about respectful maternity care, respectful maternity care, or RMC. So, three bodies, three guidelines, three images, right? So I'll just highlight the difference between labor care guide and the LCG chart. So active phase was considered from 4 centimeter. Now it is 5 centimeter. There is an expected 1 centimeter per hour flat rate progress. Now we have made an evidence-based timelines, alert line and action lines are removed, and second stage intensive monitoring has been added, right? So intrapartum fetal monitoring, the CTG and NST, this thing has been made an extensive YouTube video again as high yield topic discussion, and I want you to go through it very very carefully. It has the description of the machine, the probes, the different variants, how to look for the early deceleration, how does the variable deceleration look like, how are the most atypical sinusoidal waves, and also Apgar I think will be taught in your neonatology topics, so I'm skipping it here. But Apgar is a very important thing and you should know it by heart. Now coming to the active management of third stage of labor, I have put a triangle because it had three parts. So this is intermittent tone assessment, uterine tone assessment. Okay, previously it was uterine massage, now it is removed. It is not uterine massage anymore. Uterine massage is used in management of PPH but not in prevention of PPH. This is prevention of PPH, active management of third stage of labor. Okay, and we need to give uterotonics. Uterotonics can be oxytocin or syntocinon, or its newer generation carbetocin, which is recommended only for cesarean and not for management of PPH, only for MTSL in cesarean, carbetocin, or methergin, or something known as symptometrin, which is methergin and oxytocin combination, or misoprostol 600 microgram sublingual. All these are recommended. So any of the ecbolic. And finally, last but not the least, placental delivery, controlled contraction to be done if expertise is available. It is also known as modified Brand Andrew technique. So placental delivery by this, if expertise is available. If expertise is not available, then no need to worry, nothing extra to do. So these are certain image based questions. I know all of you know PPH very well. So this is the PPH blanket. So it has 1, 2, 3, 4, 5 sleeves and 1 aortic compression knuckle here, right? This is known as a Statinsky aortic clamp, and nowadays Piley's, which is developed by Professor VP Piley, who was my leave. So Professor VP Piley's Piley clamp. This is aortic compression clamp. This is uterine balloon. This is uterine balloon tamponade. This is bimanual compression. And see, the hand is not inside the uterus. It is pressing in a way that the both walls of uterus are opposed. And this is tranexamic acid. 1 gram is the first line drug for PPH management, and it was proven by the trial known as Women trial. So what to do in case of an atonic PPH? What all drugs can be used? This chart is again a very 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 important chart. Take a screenshot and remember it by heart. Okay. Every information in this chart is important, so I am not highlighting a particular one. Okay, so what to do in case of retained placenta? It has to be evacuated under GA. We can wait for 30 minutes. Then try you give oxytocin and wait for another 30 minutes. But if it doesn't happen, then manual removal of placenta under general anesthesia has to be given. Whatever you have seen in your institute or during your internship or wherever it is, do not write it can be done in labor room without anesthesia, because if we do that, it can cause neurogenic shock, uterine involution, and immediate death. So it has always to be done under GA, and if it is not done, then peripartum hysterectomy will be needed. So coming to the most commonly performed surgery, cesarean. So these are the indication, all P. Again, this particular table is explained there at my Instagram handle, Dr. Sunabha, and you can find it tagged in the GAMEPGAPP Instagram handle. So do read that, and remember all the absolute indications for cesarean. Coming to the skin incision, remember Fannin Steele, Joel Cohen, Mallard, all this incision is not only about the skin incision, but how we do the muscle underneath. So if we stretch the muscle, it is Fannin Steele. Same skin incision, if we cut the muscle, it becomes Charney's incision. Okay. So this is Fannin Steele is the most common incision, whereas Joel Cohen is given in a technique called Misgauw-Ladok. It is the technique preferably used in emergency cesareans. Okay. So let us know the uterine incision. So car incision is typical, the lower segment transverse incision, whereas lower segment vertical incision is also described. If there is something called classical incision, which is a midline vertical incision, its other name is chronic incision. These are other named incisions. So here if we extend the incision from midline, increase curse incision from midline, it is inverted T in is on one side, that is J-shaped. If we increase this both sides, there is trapdoor. So these are all names, can be asked as IBQ, but curse incision and chronic incision, lower segment incision and classical incision, that you should know. Okay, these are the PPH surgeries that you should know. This is B-Lynch, this is B-Lynch, this is Cho's box, and this one is Heyman's. Now remember one thing, see, the Heyman's uterus is a closed uterus. It is either post cesarean wound is already closed like this, or after normal delivery. So we have done the surgery because uterus was not contracted. On the other hand, in B-Lynch, there is a open cesarean wound. So if we are doing the surgery on an open cesarean wound, we prefer a suturing method. I don't prefer though, where the uterus is closed and compressed with the same suture. But if you ask me what I will do, I always close the uterus properly and then put Heyman's suture. B-Lynch is very complicated. So, but the first PPH surgery, remember, is systematic devascularization. Okay. So what is systematic devascularization? Systematic devascularization is when we do first block the uterine artery, then the uterine and ovarian anastomosis, and finally the internal iliac artery. First unilateral, then bilateral. So this is systematic devascularization. If everything fails, we have to do a postpartum hysterectomy, which is also known as the obstetric hysterectomy or supracervical hysterectomy, because cervix is not dissected and removed, only the corpus of the uterus is removed. So it is also known as subtotal hysterectomy. Okay. So instrumental delivery, we have a detailed video on this, so I would rather skip. So just remember the type parts of the forceps. This is handle, this is the shank, this is the blade. This part of the blade is known as the toe, and this part is known as the heel. This curvature is the maternal curvature, whereas this curvature is the fetal curvature, right? And this is the lock. So remember these images, these are described in previous videos. This is the keyland forceps, the rotational forceps, this is the low forceps, and this is the outlet forceps, which is known as the Wrigley's forceps. Wrigley's is the smallest forceps, and this is Piper's forceps used in breech delivery. This has a reverse metallic curve, reverse maternal curve, and a very long shank. This is used in breech delivery. This is used in breech delivery. Okay, so these are ventouse. This is handled ventouse, the kiwi cup. This is another handled ventouse, and this is elastic cup for ventouse application, and these are the metal cups. Remember this image carefully. Most of the time the nozzle will be on the cup, like this is also the cup, right? This is also a cup, but the nozzle goes vertically. But if the nozzle is on the sideways, this is a particular cup specially designed to deliver occipito-posterior. So thyroid disorder, only 2 lines are needed, only 2 or 3 lines. So if it is TSH is less than 0.1, it is hyperthyroid. If it is between 0.1 to 2.5, it is normal. If it is more than 10, you have to give treatment. If it is between 2.5 to 10 milliliter, this is important, you have to do anti-TPO antibody testing. Anti-TPO antibody testing. Now, if anti-TPO is positive, you should definitely treat. If it is antibody negative, then between 2.5 to 4.5 or 5.5, somebody says. So this is controversial, this will not be asked. So between this range you need not to treat, but beyond this range you might consider treating. So basically, when you find something in the range of 2.5 to 10, to understand if whether we have to give the medicine or not, we have to do TPO antibody. And what is the treatment for hyperthyroid in pregnancy? It is PTU, that is propyl thiouracil. That is the drug can be given in first trimester. These two drugs can be given in second or third trimester, but not in first trimester. And this one is a radioactive thing, and this is absolutely contraindicated. Coming to asymptomatic bacteria, every woman should undergo at least one urine culture in every trimester, unless they are positive. Because if there is a subclinical urine infection happening, that inflammation triggers preterm labor, right? So if a clean voided specimen contains more than 10 to the power 5 million per ml colony forming units of a bacteria, it is considered as asymptomatic bacteria, and it is to be treated only in pregnancy. So what is the treatment of choice? Previously we used to think nitrofurantoin is the drug of choice, but currently what we know is penicillins are likely safe, cephalosporins like cefalexin, ceftriaxone, and even macrolides like azithro or erythro. But nitrofurantoin, there is a risk of neonatal hemolysis. Quinolones are contraindicated because risk of arthropathy, early joint closure, aminoglycosides, risk of nephrotoxicity and sensory neural hearing loss, and avoid tetracycline sulfonamides at any cost. Genital infections in pregnancy are to be treated with drugs that acts through the vaginal route, not oral route. Oral route is contraindicated. Vaginal or local route is preferred. Coming to discussion on the preterm labor. So, threaten preterm labor when there is uterine contraction but no cervical dilatation. So, this is a reversible. Diagnosed preterm labor is when uterine contraction is there and cervix starts dilating. And established preterm labor is with very high uterine contraction, cervix is already 6 centimeter or more. So this extreme, very preterm, all these things we have already discussed. So preterm labor, basically this chart is very, very important. This chart you can take, you may not need a screenshot actually, just understand that any infection to the mother or any medical disease in the mother is most likely to cause preterm labor. On top of that, history of preterm delivery and shortened cervix, that is cervix which is less than 25 millimeter, is important. So what are the tocolytic agent? Isoxaprine, which is available in the market by the name of Duvadilan, nifedipine, the calcium channel blocker, which is the current drug of choice. Direct blocker is atosipan, which is very costly. Direct oxytocin receptor antagonist, drug of choice for cardiac conditions in the mother. Then Magself can be used as a tocolytic agent. Progesterone and sarclage are only effective for those with less than 2 centimeters cervical length. Steroid, we have again a detailed chart, and Magself also we have a detailed chart, detailed photos in my Instagram handle, so you go through it and I hope there will not be a problem. You see the GAMEPG app as well. And then comes the pre-labor rupture of membrane. From here, only thing you need to know is this full form is pre-labor. The old full form was premature, okay, premature, but that term has been removed and now full form is pre-labor rupture of membrane. That's it. So talking about cervical insufficiency, so this is a TVS showing the cervical canal, and this is the length of the cervix, this is the fetal head, and this is the bag of membrane. So first it remains just a thin opening, and then upper part gives away, lower part is still there, then it is already open till external os, and here external os has already given away. So the progression is like TYVU. Remember this, these are also photos that this is a very important potential image based question. So here you can see like this cervical lip has gone here, gone here, this is the head, and this is outpouching of the bag of membrane into the vagina. So antenatal USG first trimester dating, as we have already discussed, TVS CRL at 9 weeks is the best. Then coming to missed miscarriage. Now, what if the fetus is formed and there is no cardiac activity, or there is gestational sac but there is no fetus? So in those conditions, if cardiac activity has come and disappeared, then it is definitely missed miscarriage, even though there are no other features of miscarriage. If there is mean sac diameter more than 25 but no fetal pole, or crown rump length is more than or equal to 7 millimeter but no cardiac activity, in those conditions we can define it as missed miscarriage. Now the image that can come in your exam might be as good and clear as this one, or very blurry and grainy like this one, but you should be able to understand. So next is NT scan. NT scan is done between period of gestation 11 to 14 weeks at a CRL between 45 to 84. There are certain criteria that has to be remembered during NT scan, but this much is very important, that NT scan is a part of the aneuploidy screening. Now aneuploidy screening, there is again a very beautiful chart depicting all the markers and how they vary in my Instagram account, so do follow that. NIPT is non-invasive prenatal testing, which is basically estimating, extracting cell-free fetal DNA from mother's blood circulation and doing all the genetic testing with that material. Invasive fetal testing, amniocentesis, chorionic villus sampling. Amniocentesis is like when we take out the amniotic fluid immediately surrounding baby and try to harvest fetal cells. Chorionic villus biopsy or sampling is when we take a part of the placenta for biopsy and test it. And chordocentesis is like we saw during our intrauterine transfusion, we take sample from the cord to analyze. So these are the invasive fetal procedures, and these are, if they come in exam, actually these are a bit difficult procedure. CVS is done usually between 11 to 13 weeks, whereas this one is done between 15 to 18 weeks. Chordosynthesis can be done anywhere after 22 weeks. So this is important. This is previously known as anomaly scan or level 2 scan, which is currently known as TIFA, targeted imaging of fetus for anomalies, right? So this is TIFA. You can I think radiology faculty will be discussing this in details, like gross abnormalities like this sacrococcygeal teratoma, cervical spine abnormality, or this thoracic spine abnormality. All these things can be find out in TIFA. If you see a growth scan, 4 parameters: biparietal diameter at the transthalamic plane, head circumference, femoral length, and abdominal circumference is measured, of which abdominal circumference is most important for growth. Remember, growth scan is never done single, but it is always an interval scan. So 4 weeks, between 4 weeks interval, we do 2 scans and see if the fetal growth is corresponding to 4 weeks or not. So let us see FGR in short. So if it happens before 32 weeks, it's early onset, whereas it happens after 32 weeks, which has a better prognosis, is known as late onset. So estimated fetal weight less than 3 centile, AC less than 3rd centile, or anything between 3rd centile to 10th centile with Doppler abnormalities, gross Doppler abnormalities like AEDF, REDF is known as, this is Barcelona definition. So when the blood goes from the mother to the fetus, it is like this. So there is more flow during the systole, less flow during the diastole. So if the fetal resistance is so high that during the diastole there is no blood going to the fetus, like the graph is like this, this thing is not there, like this. Only during systole the baby is getting blood. So this is absent end diastolic flow, and the resistance might so increase that the blood flow is from the fetus to the mother during the diastole. So that is known as REDF, or reversed end diastolic flow, right? So this is also known as sine curve. Level of the fundus, very basic, just palpable, 12 weeks. Then at the umbilicus, 14 weeks. Then at the xiphi-sternum, 36 weeks. So 24 to 36 is 12. 12 to 24 is 12. So we can divide it in 2 parts. In between 18. And here in between 30. Right? And also after 36 weeks, once it becomes 40 weeks, the head engages and the fundal height actually comes down. This phenomena is known as lightening. Okay, one of the important phenomena of second trimester is quickening, when the first fetal movement is felt. That is 15 weeks in multi and 20 weeks for a priming. So this is one of the important phenomena of second trimester, quickening. Third trimester, important phenomena is lightening. So coming to the episodes of bleeding in pregnancy, the differentiation could be abortion, which has again a very detailed video on YouTube. So go through that. Then it can be ectopic. It can be due to abruptio placentae, placenta abruption, or the Parkita spectrum. So ectopic pregnancy, the new nomenclature has come, but I think you need not to focus on that too much. So if it is a cervical ectopic, tubal ectopic is most common. And among tubal ectopic, most common site is ampulla. The ampulla. If it is a cervical, then Rubin's criteria is to be applied. If it is ovarian, Spielberg criteria is the diagnostic criteria. Studiform criteria is for abdominal ectopic pregnancy, which is really rare. Bleb bleb, bagel or ring of fire sign is seen. Bleb, bagel or ring of fire sign is to be seen in normal tubal pregnancies, normal tubal ectopics on USG Doppler, right? So this is the estimation of hemoperitoneum. If the pouch of Douglas has fluid, it is 1. Pouch of Douglas has clot, it is 2. And grade C is when the uterovesicular pouch also has either fluid or clot. So medical management criteria and regimes. Medical management is usually done with methotrexate. There is 1 dose regime, 2 dose regime and multi-dose regime. 1 dose regime, 2 dose regime and multi-dose regime. So 1 dose regime is we give the drug and measure for fall on day 4 and 7. 2 dose regime is we give the drug on day 1 and day 4 and measure the fall between 4 and 7 days. Multi-dose is when we give the drug on 1, 3, 5 and 7. And here in this one we give folinic acid rescue, leucovorin rescue on 2, 4 and 6. Remember, if there is cardiac activity plus, if sag diameter is more than 3.5, if beta HCG is more than 350, sag diameter is more than 3.5 centimeter, cardiac activity is there, and there is evidence of rupture or hemodynamic instability or a contraindication to methotrexate, then medical management cannot be done. Medical management cannot be done for that woman. Surgical management is either salpingectomy, where is removal of the tube, or salpingostomy, where we cut the tube and extract the for abruptio placentae, you need to understand the 2 types of placental separation. One is central separation like this, and then separation becomes like this, and finally the placenta comes out revealing all the blood at once. On the other one is like it separates from side to side, so you can see a trickle of blood from the beginning itself. So this is concealed and this is revealed. So concealed is basically when there is a huge subchorionic hematoma developing and suddenly a gush of bleeding, right? So Page's classification, the name is important, the classification as such is not important. Page's classification, class 0 is incidental diagnosis and class 3 is either a fetal demise or maternal shock. So this is also something very important, this chart. Just take a screenshot of it and revise how to differentiate placenta previa versus abruptio. So previa is usually painless, whereas abruptio is painful. USG, there will be low placenta, there will be retroplacental hemorrhage. So this chart is something which is very, very important and you should know by heart. Now placenta previa, there was this old classification. So this is the uterus and this is the cervix. So if it is coming in the lower segment, grade 1. If it is going till the cervical edge, it is grade 2. If it is covering the os but will be open when the os fully dilates, 3. And if it is completely covering the os, is type 4. Now TVS based type is, if it is around 2 centimeter near, it is placenta previa, and it is covering the os, it is low placenta, and it is covering the os or within 1 centimeter around it, then it is placenta previa. So these numbers you need not to remember, but the new classification is TVS based, that you should know. Then what is placental adherence spectrum? If the placenta is invading the endometrium, it is accreta. It is goes into the myometrium, it is increta. And if it is goes beyond the uterine serosa and goes into bladder and anything, then it is percreta. The management for all this is usually postpartum hysterectomy. Coming to the hypertensive disorders of pregnancy, one of the major things. So this definition, this is the definition. So de novo in pregnancy is transient gestational hypertension, and preeclampsia. It can happen before hypertension was already there before 20 weeks. It is chronic hypertension. You should definitely know what is the definition of massive proteinuria. This is very important. And most importantly, you should know this chart. Take a screenshot of it and remember. So, what are the severe features of eclampsia? These are the severe features, right? So, prediction is by maternal risk factors, maternal BP, something called PLGF, and uterine artery waveform analysis. And what are the preventive things? Low dose aspirin, high dose calcium, exercise at least 3 days a week, 50 minutes each time, aerobic or aerobic plus strength plus flexibility. So delivery timing is really important. For REDF 30 weeks, for AEDF 34 weeks, and for other things 37 weeks, right? So very severe REDF 30 weeks, otherwise something very severe 34 weeks, something less severe is 37. Finally, this is MGSO4, how to give, when to give, what are the things. So again, if you see the GAMEPG app Instagram handle or my handle DRSUNABHA, you will find a detailed description on magnesium, when to give, when not to give. So I'm not going into that details right now. We'll continue with the next part of our discussion after a short break.